Welcome, welcome, welcome to Pour Myself a Cup of Innovation. You have chosen the best session at ViVE. I don't care what the other session told you. I'm Dr. Chris DiRienzo. I'm the Chief Physician Executive of the American Hospital Association. And when they asked me to moderate a panel on innovation here at ViVE, I was like, it's like the entire freaking conference, right? Everyone here is talking innovation. But what we get to bring you this morning as a bridge to lunchtime is some words of wisdom from 4 terrific innovators in our field. And the focus of today's conversation really is how innovation gets to bedsides and gets into healthcare operations. Now remember, what we do in hospitals is unique. Healthcare is and will always be a uniquely human experience. And the folks on stage here have some direct experience in making sure that when we innovate, when we bring technology, that we never fail to thread that needle with the fiber of our humanity. We've only got 45 minutes. It's going to go really quickly. We've got some pre-prepared questions, and if we have time, we will try to get to some good Q&A with you from the audience. So in order to both save time and get right into the meat, I'm going to ask each of our panelists to both introduce themselves and share their single best, bottom line up front, story from their own personal experiences of bringing innovation into the hospitals and health systems where they work. And Kieran, we will start with you.
Thank you, Chris. So I'm going to talk about an innovative approach we use called the two-speed approach. But before that, introducing myself, my name is Kieran Mysore. I'm the Chief Data Analytics Officer at Sutter Health. Sutter Health is a large not-for-profit health system based in California. Our vision is really to help our patients experience better lives. We serve 3.5 million patients through 24 hospitals and many ambulatory service centers. You know, our vision is, again, to be the most connected, most integrated, and most coordinated health system in California. And the challenge we face is, you know, our patients, they face too many barriers to healthcare. And our goal is to remove those barriers, and data analytics is at the center of that. And my team and I lead the way to enable the best insights, the best capabilities for our stakeholders that include the hospital staff, the physicians, and so on. So what is the two-speed approach? Speed 1 is essentially moving at the speed of the business. So helping our physicians, helping our hospital staff really be at the forefront of the care so that the insights and the capabilities that we can provide them can actually translate into patient care. And it's important to be nimble. Speed 2 is really the speed of foundation building. And so you can't be nimble and fast without the right data foundation, the right data governance, the right data algorithmic governance. And so it takes time to build that. And the trick is to blend the two in the best way possible. So think of speed 1 as the cars on the freeway. You want to get your passengers to the end state as quickly as possible. And then speed 2 is really building the highway itself. Mm-hmm. And you have to sort of do both to make sure the traffic is flowing the best way possible. So we built a tool called the Sutter Navigator, which is a one-stop shop for all our operators, our hospital staff, where we consolidate a lot of patient care, volume metrics, and a lot of different insights so they can actually provide the best quality of care. So we approached it with a two-speed approach, and it's been a great success.
I love that, the two-speed approach. And we'll get a little bit deeper on how that breaks down barriers to innovation and care. But let's move on to Nasim.
Sure. Everyone can hear me? All right. Seems so. Hi, everyone. Thank you for attending this panel right before lunch. I'm Nasim Eftekhari, and I lead Applied AI and Data Science at City of Hope. City of Hope is one of the largest cancer research and treatment centers in the nation. And my team is responsible for applying machine learning, and AI, generative AI, and advanced analytics in the areas of patient care, as well as business operations and research and precision medicine. I have an actually interesting story that just came to me before I walked on stage. A few years ago, I was having this existential crisis about, am I doing the right thing? Because my background is all in computer science and machine learning and AI. And I was like, am I doing the right thing being in healthcare? And am I really making an impact? So I was having this conversation with our chief medical officer, Dr. Trisal, And I was telling him, how do I know I'm focusing on the right problems? And he said, Nasim, I'm going to give you one problem that if you solve this, your statue is going to be on our main campus. And he said, when my patients come to me as referrals from other places, City of Hope sees a lot of very sick patients. And some of our patients are 20 years into their cancer journey. They have been to many different places, and they have seen a lot of different doctors. And when they come to us, they sometimes come with like more than 1,000 pages of PDFs, scanned documents, images, even write handwritten notes. And he said, if you can get all of this and you can give me a summary of what the patient has been through, so far, so I can make decisions moving forward. This is one of the biggest pain points that we have for new patient onboarding. Fast forward a couple of years. At the time, we started with, this was before ChatGPT boom. So we started with GPT-3 and we started developing, and we've been doing this, iterating with our physicians for 2-3 years now. And actually in March, this solution is going live system-wide to help all of our physicians with their new patient onboarding.
That is spectacular. I've got to be honest, clinically I'm a neonatologist, and I think one of the reasons you go into neonatology is to not have 1,000-page PDF charts, because our chart starts at like page 0 at the very beginning. But I can see how, for your patient population, that degree of service and teeing up your clinical professionals, that's just terrific. Dan, introduce yourself, please.
Yeah, Dan Schoenthal, Chief Innovation Officer at MD Anderson. And being at a technology conference and being the innovation officer, I'm going to give you an anti-technology story. But I think it's an important one. So several years ago, we had a leader that came to my team and said, we're building this new building. And when patients come into a building that have cancer, they're scared, they have anxiety, they're frightened. Let's put all of the technology in there so they can easily walk around the building. Let's put facial recognition in, help them navigate, help understand where their next appointment is. And when we started to engage patients, they actually told us they wanted, half of them, actually the majority of them, told us they wanted the exact opposite. They wanted somebody to come up to them and just have a conversation. They wanted to be greeted. They wanted that human touch. So what we actually did in the end was the exact opposite of the ask, which isn't unusual for an innovation team to do, which was actually create a whole service design for the front entry of this new building. And it was really interesting because afterwards, there was a lot of skepticism from that leader if we would be successful. And when we started to get the patient feedback surveys, they said, all of them resoundingly said, we thought we walked into the wrong building. We've never had an experience like that at MD Anderson before. It's usually very crowded. It's usually just a flowing through a building and guessing where to go. We've never actually had somebody come up to us and just ask us how they could help us. A very simple question changed the entire day for those individuals. So it was very interesting, and I bring it up only because I think it's an example of sometimes we have to think about technology second and not forget that human interaction might be the innovative thing to do.
I love that example, Dan, in part because it makes us think about the delta between the innovation and the design. Mm-hmm. And I'm hearing you say you listened to what people wanted in design, and then you can use innovative approaches to design innovative technologies to then deliver on that. But you started with first principles and tried to design the experience that your patients were telling you, this is what will help us go. I love that. We have one more introduction. She's a pediatrician who shares a 4-syllable last name, as I do. Dr. Lozavatsky, please introduce yourself and share your single best story with the audience.
Thank you. Hello, everyone. My name is Margaret Lozavatsky. I am a general pediatrician. I practice as a pediatric hospitalist, and I am the Vice President of Digital Health Innovation at the American Medical Association. I sit in the mission area of the AMA, where our focus is on how technology can support our clinicians. And prior to joining the AMA, I have been in multiple CMIO, CHIO roles, and so have spent a lot of time thinking through how can we implement technology in a way that will best enable our clinicians to care for their patients. And so the story that I wanted to share with you, similar to Dan, is also not necessarily about innovation with new technology. what I have learned over the years is that we've implemented a lot of tech, and sometimes it is a hit, and other times there are challenges with how it is integrated into our clinical environment. And so I'm going to share a story with you that is from many, many years ago, but I think highlights the importance of listening to our clinicians. So I was engaged, over a decade ago now, in a project to improve clinical documentation. And as you know, this is something that all of our physicians spend many, many hours doing, writing our notes, and it's often a struggle. And what became very clear is part of the challenge was that they were bringing all the information into their note because they couldn't find it in the chart. And so what we did is we took a step back and asked them, what do you need from the chart? And they said, I just need one place to go to get everything I need. And of course, I'm an inpatient physician, and so I really felt this need because I experienced it myself. And so we just created a report that had all of the things that they needed. There's already tools similar to this, and we collated them together in one place. And the amount of feedback I received for the simple innovation, if you will, was unbelievable. People were hugging me in the hallways because they said they enjoy rounding. Everything was right there for them. They could write their note faster. And this, again, is a great example, I think, of the fact that if we really understand of what's happening in those clinical areas, and we can find innovative ways to adjust our current technologies, we can really make a difference for both our clinicians and our patients.
It's so true. Innovation doesn't necessarily have to be complicated, right? Sometimes the best innovations are just these small tests of change, small tweaks to process that lead to massive delta in outcome. When we think about improvement in healthcare, right? Like if you get 1% better every month, by the end of the year, you're like 11% better than when you started. 1% better every week, and it's like 66% better. But just that little 1% tweak every day, a year out, you're like 3,740% better than when you started. And it doesn't have to be complicated. It can be as simple as that kind of report, or as tools to help with bilirubin in the NICU. I love those examples. We're going to get into a couple of our prepared questions. I can already see some Q&A building from the audience. Thank you for that. Keep sending them in. We will try to get to as many as we can. This one goes first to Nasim and then to Dr. L. You're both really trying to get into the real-world application of innovation, both in operations and at bedsides in hospitals. But we know, as folks who work in hospitals, that there can be many barriers to making innovation in healthcare fast, right? Speed to innovate is a challenge. So first, from a data scientist perspective, and then from a doctor's perspective, talk to us about why you think that is. And then, perhaps if you have some guidance for how you have actually approached breaking through one of those barriers.
Sure. So the biggest barrier from my perspective is change management and cultural shift, and changing people's mindset to start using these technologies. I've had a ton of projects over the years that have failed, and it was never about the technology or how good or bad it was. It was always about it not being adopted. So I have a lot of lessons learned. Maybe some of them that are more important are, I have learned that we should develop for our clinicians. We should develop with our clinicians, not for them. And so we engage our clinicians from the very first step of ideation to development, to deployment and after, and we make sure that we keep that communication going to make sure that we are solving the right problems for them. And once this tool is actually available, they will use them. So that's one thing. The other thing, which is a big challenge, I won't say that I have a good solution for it, is when we develop AI, data science, analytics solutions for our clinicians, we are dealing with a little bit of a chicken and egg problem, because we're trying to help our clinicians save time. They are extremely busy, and we're trying to help them save time. But at the same time, for this to be effective, they have to spend a lot of time helping us. Sometimes it's with, annotation of images for diagnostic tools. Sometimes it's with labeling data. Sometimes it's with validation. So we are asking them, on top of everything that they're doing, we are asking the people, we are trying to help them save time to spend more time with us. So that's something that has been a big challenge from my perspective. And this one I have no solution for.
Dr. L, you see that from the other side. Tell us about your thinking.
Yeah, and I agree with everything that has been said. I think it's so important to engage our clinicians. And so when I thought about this question, I came back to a time in our lives where innovation moved quickly, which was during the pandemic. And I think there's a lot of lessons to be learned from that period of time. You guys probably all know that it usually takes several years to implement a new technology in a major health system. And here we were during the pandemic implementing things in a matter of days sometimes because we all shared a common goal and we were all working together. The other thousands of priorities went away and we had to get to a place where we had solutions to be able to see patients in virtual environments and to support our clinicians that were in various areas across the system taking care of patients in a different way now. And so I think that that's a large piece of this is understanding the priorities of the organization and aligning them with the needs of the clinicians. And this is not a simple challenge, and it really comes down to governance and having a process in your organization to get a quick feedback loop from the folks that are caring for the patients, understanding their needs, understanding what their pain points are, and also aligning the solutions with the high-level needs of the executive leaders at the organization, and thinking about the workflow of the clinicians. How can you support? How can it be additive? I had a colleague that would say, if you build it, they will not come. And many of you have heard me say this over the years because it's always in the back of my mind that if we are not thoughtful and we do not integrate technologies, they will not be successful. So those are some of the lessons that I wanted to share from a clinical perspective that I think are important for us as we consider innovation.
And there's nothing like a once-in-a-century pandemic to make alignment really clear, right? I was the chief medical officer of a 3-hospital system in North Carolina at the time. And you're right, when faced with like existential threat, it's pretty easy to align around things because lots of our other work falls away. And then obviously we have to get back to that other work. And we walk through what we're walking through now. Both of you brought up end users. And so just one quick follow-up before we get Kieran and Dan to the question I have for you. You know, Nasim, I heard you say that on the end user side, sometimes it can be challenging for I'm a doctor, so I will say doctors, to get engaged in that early design process. You know, and I think you're exactly right that one thing that we talk about certainly with practicing physicians is in order to have a voice in the game, you got to have a voice in the game. And if you make the mistake of designing a technology without the end user as part of you make that mistake exactly once. And all of us have made it, I am sure. But have you found, what's been a way that you found successful in helping end users understand, here's why we want you to be part of this process, because you can actually have this change in what we're going to build and how it's going to look at the end. Have either of you seen something that works there?
Well, we've found the best success in working with physicians who actually come up with the idea of the project. So most of the things I've worked on, at least so far, have come to us from the people who are experiencing that pain point. So it always helps. And then we work with them. We call them physician champions. So our physician champions help us socialize with the rest of their colleagues and, you know, sometimes different specialties when the tool is ready to be extended beyond the pilot phase. So we found a lot of success working with our physician champions, and the more time and energy they have to dedicate to it, we found various levels of success.
I love that, and it goes both ways, right? Like, if you've been the CMO of a health system, you know that doctors frequently ask for a tool. And what they're really looking for is an outcome, right? They don't need the quarter-inch drill bit. They really want a quarter-inch hole, right? So I love that you all are so willing to be that engaging. That speaks really highly of health systems. I have another question, Dan, to you first and then to Kieran, because you both bring engineering mindset into healthcare. And having spent like 20 some odd years working in patient safety and quality, we desperately need engineers, bringing your unique skill sets to helping our operations. You shared a little bit about your innovation frameworks at MD Anderson and in your health systems, but what is let's say, the single biggest process step that leaders in healthcare today either shortchange or just don't think about enough when it comes to trying to build their innovation framework?
Well, first, Dr. L and Nasim stole my first answer, so I'm now going to invent one on the fly. But they're absolutely right. The bookends are usually forgotten. Do we have executive buy-in? Is this of strategic importance? And do we have the people where the change is going to occur involved in the process throughout? Those are like the two critical steps, because innovation's hard. If you really think about innovation, we typically have to pull together IS teams, compliance teams, regulatory teams, other legal teams, on top of our clinicians, our providers, the patients themselves, the patient's family, and everyone else involved in the care journey. I think the thing that we've seen outside of those bookends is really then in between you have moments where the path that you were going is changing, but you're so focused on what that original problem is, you lose sight of the fact that there are signals there that maybe you need to change your line of thinking. So to your question around how do you convince providers to get engaged, what I would say to that is, if you really have to sell providers to get engaged in an initiative, maybe your initiative isn't worth their time to solve. And maybe that's a signal that I should really think about this, and maybe I'm not thinking about this right, because what I've seen, at least at MD Anderson from our providers, if we're tackling something that is critical to them, they'll figure out how to make time. They'll be passionate about it, at least a handful. Maybe not everybody, because some people don't or resist change.
Or parking. If you're having any conversation about parking, then in my experience, everyone will find time.
Everyone will find the valet service. Yes, we could spend a whole hour on innovating valets. But I think that's a signal to me. So understanding outside of the bookends, which are perfectly covered, understanding the signals for maybe I need to change my thought on what I'm trying to tackle here.
And so just to go one level deeper, Kieran, before we hear your answer from some Sutter's perspective, how do you create an innovation framework that allows for that to happen? And because that's non-trivial.
It's not. It is, honestly, at that point, the leadership are trusting you. It is the frontline teams. Because it's really working with them to say, you know what, we were headed down this path, and just having an honest conversation of, I think we were wrong. Do we have, and creating an environment where it's a little bit different than what they might go through day to day, because you as physicians, very regimented steps, you're caring for lives. This is saying, hey, we might be completely wrong, and it's okay, physicians, to be completely wrong in this scenario. This is a safe space. So it's really creating that just mental model from day one where we actually expect to iterate. If everything goes smoothly, we're probably not challenging things enough. We expect there to be some level of friction and anxiety throughout the process, and that's okay.
That's a great model to create, not just for physicians, and I speak to physicians because I am one, but nurses, respiratory therapists, lab techs, rad techs, I mean, you name it. All of us involved in healthcare, it's a hyper-regulated environment. We have this sort of sacred mission and approach to what we do, and so it is a different step to think about, fail fast, right? And you have to create the right sandbox to do that within. So Kieran, I know you do this well at Sutter. With your process, what is the one biggest step that people just forget just how important it is?
So you asked for an engineer's perspective, right?
Yeah.
And the engineer's perspective is always to be enamored with all the technology and the data and get wrapped up in it. But the single biggest thing I've learned is really something that I'm going to echo my colleagues' sentiment, which is culture and adoption is huge. I've read a lot of studies, from the likes of, Bain and McKinsey, where they say 70% of digital transformations, even in healthcare, actually fail. And the single biggest reason they talk about is because of culture and adoption. And so at Sutter Health, one of the things we do is really take a very systematic and a very methodical approach to this. So when we start to roll out new technologies, obviously, we want to start small. We start with pilots. When we did ambient listening, for example, this was a project that we did to roll out, ambient technology across the ecosystem. We chose a very small set of physicians who are excited about it, who are willing to work with the kinks in the system and actually advocated for it. And when that was successful, we were able to roll that out to more than 1,000 physicians after that in phases. And so that start small and scale is a very key element of all of this. The second thing is we think about the end user or the patient experience. It's not even through the physician, but actually the end user or the patient. So when we implemented in-basket messaging, one of the key things we wanted to do is to make the message a lot more empathetic and a lot more humane in response to a patient query. So we actually enlisted a lot of patient advocates in Sutter Health who actually know and work with patients, and they actually read our messages and actually said, hey, this one is less empathetic, let's tweak the model a little bit to add that empathy into the mix. And so we wanted a Sutter language in the responses. And so thinking about the end user and tweaking the technology and really making it better was another step. And the third and the last one I'll quickly state is we created a digital academy to roll out new technology. And I think this is important because the academy actually has key roles like a digital ambassador or a sponsor or a workflow expert. And I think the combination of all of these roles helped us really recognize who the end users are, who the physicians are, and how they would actually use it in the workflow, and actually roll that out in a more methodical way. So I think these are the three sort of big things. And I always say, change ultimately is hard, but change clicks when culture sticks. So.
Change clicks when culture sticks. Whoever's taking quotes from the session, that is clearly going to be one of them. We've got a little bit under 20 minutes left. I'm starting to see some good questions rolling in the chat, and so I'm going to jump to one of those now before we get to our last question, because Kieran, you sort of began speaking to it. Building a culture within hospitals that is friendly to innovation is really hard. And it's hard for a lot of good reasons, right? There are some parts of our world where we need it to be difficult to change. We live again in a world where not only are there lots of regulatory bodies, but we're dealing with people's lives. And so how, and sort of a free-for-all, whoever wants to jump in first, how have you, as spectacular leaders in innovation at health systems, thought intentionally about, in order for us to be successful, to get across this bridge, our culture needs to look like this, this, and this. And that means that I need to build these things to make that happen. Kieran, you started there, but I'm wondering who would like to jump in on that one?
I'm happy to jump in. One of the things that I think has been really critical to developing this kind of culture is talking about governance, and I alluded to that earlier. And it's a topic that's not as exciting as new technology, but that's what really allows for some of this culture change over time, and really getting the right voices at the table so that you can create an environment where those are the problem solvers that are thinking through the different ways of doing the work that we do. And the other thing is it's an iterative process, and understanding that and building that into your vision of how to bring innovation is really important. Allowing space for a feedback loop where you set the expectations from the beginning. This isn't going to be perfect. We're going to work together to make it better. And you really listen to the feedback and incorporate it into what you do. I think really helps to transition some of that culture. And in the end, makes the innovation cycle much faster.
Love it. Others who want, please.
I wanted to just make a comment. Maybe it doesn't answer your question, but I've been at CDFO for 8 years implementing AI, machine learning first and now generative AI. And I think it's got much, much easier after the generative AI boom, because ChatGPT first and then the others, they made AI accessible to everyone and democratized. So now people are more excited. I know that a lot of it might be hype, but it's just if you have used it to, I don't know, for it to write a good joke for you, and if you've used it to write your emails for you, you know how powerful it could be. So, a lot of people that I've worked with over the years are suddenly like, oh, so this is what Nasim was talking about, that AI could do ABC. So I think it's got easier, at least for us, now that everyone at least knows a little bit and has some exposure to AI.
Awesome.
I think one thing that I've heard, just given my title, that we can't forget is there's some folks on the front line who have actually come to me and said, Dan, I'm not creative. I can't help you. And I'm not the innovation person you are. Go figure it out. But they have a fear of, I'm not going to bring enough interesting things to the table, so I'm afraid to engage. And so part of the cultural shift is there are no bad ideas, but also we all have creativity inside of us. My team's job, I look at it as bringing that out of people and running a process of innovation that gets the creativity out of those on the front line, our patients. So part of it is there could be this word innovation causes some anxiety with folks who are just afraid to engage because they're afraid they're not creative enough, that you have to have the biggest dream ever or the greatest idea for it to be a home run. So creating an environment where that isn't the goalpost is also critical to me.
I love that. It reminds me of sort of the early stages of quality, where there was an office and quality people did quality over there. But really, that fundamentally changed, I think, when leaders in healthcare quality began going to the Gemba and being willing to get into like the hard, challenging work of people's. I remember, we'll never forget this. We were doing one performance improvement project that was shifting the schedules for this particular therapy team from what they had, which was handwritten, onto an electronic platform. And they were so strongly opposed to it because they understood what they were doing. We walked into the room, and I kid you not, it was like a 40-foot whiteboard that had 19 different magnets. And the magnets didn't just matter what color they were, what direction the magnets were facing, that was a signal to people. And so like we just get so accustomed to our daily work, right? That we can be scared to innovate because change is scary. And we have to go through that valley, right? And that valley, we don't know how deep it is, we don't know how long it's gonna last. That can be hard. Terrific examples. We are beginning to run a little bit short on time, and so I have one question that I absolutely have to ask you all before we jump back into the audience Q&A. And that is gonna first to Dr. Lozovatsky, then Dan, Kieran, and closing with Nasim. And so if you happen to be in a room of 8,000 of your best friends who all worked to either fund or build innovation, and or were really working hard to try to get that innovation into hospitals. Just hypothetically speaking, what one piece of advice would you give to them to help them better understand what our worlds actually look like once you cross the threshold behind that big blue H?
Great question. Lots of lessons learned, as you're hearing, by each of us having done this before. If there's one thing that I would say to folks that are looking to bring their solutions to a healthcare setting, it would be to listen and to not have any preconceived notions. The tools that often people build, the technology may be solid and it may be really fantastic and might have the potential to change the way we deliver care. The devil is usually in the details. And integrating technology into a clinical environment is complex. And we talked a lot here about the needs of the clinicians. They are busy. They are caring for patients. I love the comment of, if you're bringing something to the clinicians and you can't get them to engage, maybe you're bringing them the wrong thing. That's your first lesson. If people don't want to try your technology, then maybe it's not solving a problem that they have, and you may need to think about how to present it in a different way. Integration is key in this conversation. How is it going to be a part of the existing infrastructure at that hospital, and how is the clinician going to use it? The worst thing you can say is, you just need to open this other window and everything you need will be there. Because I already have 20 windows open when I'm caring for patients, and it's the last thing that I want to do. And finally, I would say, make sure that you're engaging the people that are closest to the care. So when you're asking those questions, ask the people that are going to be using your tools, and listen to them and make changes that are necessary to be able to support them, so that ultimately we're all there to care for patients. We're there for the patient. And if we don't hear the people that are part of the work, we're not going to be able to provide the best care.
Thank you. Dan.
I think what I would tell 8,000 of my closest friends who may or may not be in earshot of me, those of us on this stage and some of the people in the audience, I see members of my IS team, I think back there in the lights, we get probably 50 to 100 emails a week of, I've got the greatest technology, you've never seen it before, and I don't know how it's physically possible that there's 100 companies a week that have the greatest technology ever. We ignore those things. And so the advice I would give is be really, and it's building on what Dr. L said, be really, really passionate about the problems you're solving, not the technology itself. The technology is becoming more and more of the commodity. The interesting and unique way and the depth of understanding that you have about the problems that we face on a day-to-day basis is actually the thing that gets you in the door, and it's actually what will cause opportunity for you to have conversations with those frontline teams, engage leaders who are making decisions. Leading with technology is a very quick way probably for all of us to say, this sounds the same as the last email, I'm just gonna file it away. So really be passionate about the problems you're solving and less so about the specific technology you're using to solve it.
Awesome. So I agree with everything that is said, and at the risk of sounding like a broken record, I think listening is key. The one angle I've taken on is really, my advice is really understand the workflows really well. And workflows are very key because the technology is only one part of the equation. How you integrate it is really important. When I talked about the Sutter Navigator, this tool that we built, our first inclination was, let's go build the best dashboard that looks really cool and let's roll it out. We actually spent time with our operators and our hospital staff learning about how they do operational reviews. And we learned a lot. We learned, for example, that they like to focus on exceptions first. We never thought of exceptions first. We thought, let's show all the data. So that was one. The second thing we found was, well, they actually wanted to assign action plans to every hospital administrator based on the exceptions. So we built a whole action planning tool as part of that, and that integrated really well into their overall ecosystem and workflow. And then we realized in the morning, there's bed huddles and there is hospital huddles that happen at every hospital. Well, we understood how they did that work and actually recalibrated the dashboards to enable real-time access. So I think understanding the workflows is really good. I think that's where I would leave it at.
Understand the workflows. Final comment on this one.
Sure, a lot of great things were said, so I won't repeat them. But I would say if you are an investor looking to invest in a company, or if you are an executive looking to invest in any kind of technology or innovation, I would recommend not only, but mostly invest in people, because in 2025 and beyond, it's not about who has the best technology anymore. It's about who knows what problems to solve. And so I would invest in people and in partnerships that can enable bringing together the technology and the people who know the problems very well.
We're into bonus time, and so there's a question from the chat that builds on your notion about problems. And I think I speak for all of us when I say we know that members of our team understand their challenges very, very well. But there are lots of challenges that a health system can face. I remember a lot of my job as a health system chief medical officer was answering doctors who would come to the office and say, I need this thing. And I'd say, well, we can't buy that thing. We also have these other 13 things that we need to figure out how to align. So it takes an interesting approach to have conversations with your team members, and not just docs, but nurses and people who work in revenue cycle and people who work in the ambulatory clinics. When you need to lead innovation, how do you approach opening the aperture of folks who are working in the front lines, who perhaps don't get to see the impact of some of those other big problems that maybe you're needing to spend significant resources as a hospital in trying to solve for?
I'll jump in. I think having transparency across the institution of all of those things that folks are working on is really important. And I recognize it's easier said than done. What I have found is that having a transparent process where all requests are prioritized in a similar manner, and there's a feedback loop to the requesters that clearly identifies where they are, is so critical to people feeling heard and understood. And even if the answer is not right now because we're doing all of these other things, or your request is part of a project that will happen in a year, or it doesn't align with our strategic priorities, whatever it is, the fact that there is a response and it's a response that explains the reasons behind whatever the decisions are really helps people to continue to stay engaged. Because the worst thing you can do is to hear I don't even ask for things anymore because they fall into a black hole. Having that feedback mechanism is really important. And I'll just share that one of the things that we had done is that we created a newsletter that said, "You spoke, we listened." And we started sending it out first on a monthly basis and then on a weekly basis. And we opened every meeting with that. All of our government's meetings were opened with all the things that we did do, because there's lots of work that's happening. And that was incredibly well received. I heard across the board how important it was to people to feel heard. And so that's just one approach to communicating all the things that we were doing.
I think, Dr. Al, you're pointing out another cultural thing where when things go to innovation groups or innovation functions, however they're dubbed, I look at our job as not just saying no. It's how can I help you? And that might not be the full vision that you have, but maybe there's a step that we could take and explaining where it fits in. But the answer usually shouldn't be no, it's maybe not right now, or maybe here's a portion of what we can do to start to help you, and this could fit into something larger in the future. That's what I found a lot, is the thing that's a no today, usually in a year comes back around and is some sort of large institutional priority, and then magically it's a yes.
There you go. Here.
I was going to quickly add, I mean, from an innovation perspective, sometimes it's also important to inspire the art of the possible. And one of the things we've done at Sutter Health is to create an innovation center. And we are located right on Pier 1 in beautiful San Francisco. And it actually inspires. We did a whole journey mapping of the hospital of the future and the clinic of the future. And we actually mapped that out on big boards and set it up in the innovation center so people can actually see it and understand it and actually comment on it. And sometimes we get the best feedback when people actually look at it. So inspire the art of the possible.
Nasim, last word to you.
I mean, I couldn't have said it any better. I think it comes down to communication, transparency, and being vulnerable, letting people know we don't have all the answers, we don't have the best solutions all the time, but you're here to help. I found that to be very helpful.
I love it. I love it. I'm going to borrow moderator's privilege and answer my own question for just a moment, because it is not every day that I get to sit in a room with 8,000 friends and family members all committed to innovation in healthcare. And my message to you all, because I spend about 150 days a year on the road in hospitals, much like these on stage, but also much smaller and much more rural ones. And you all are leading innovation in the country, and that is spectacular. Don't forget about our friends in rural America and how innovative they have to be. I was at a hospital in the Plain States recently, 2 beds. They have a medical staff of 4. So in their emergency room, they don't see a lot of trauma, but they practice, they rehearse, they sim. And then, God forbid, there's the day where someone falls into the machinery at the one large factory, which is the big employer in town. They press a button on the giant flat screen that's on the wall, and they get board-certified EM doc, ATLS nurse, and respiratory therapy immediately available to them. It's that kind of innovation that when you choose to serve rural populations, hospitals need to be doing. So yes, our friends in big systems, have really terrific leaders leading innovation. Academic centers do a spectacular job. But remember that oftentimes it's these places in rural America, these small hospitals, that frankly are faster to innovate. And because if they don't, then their challenges in serving the communities are even more greatly magnified. And we bring rural hospital leaders together at the AHA, actually I think next week in San Antonio, like well over 1,000 of them. It's one of my favorite places to go because you hear stories like this with small teams, all grounded in this 24/7, 365 service to their communities, and they're operating right at the edge. You all are creating that edge. You are leading the edge. I would ask for a round of applause for the best panel at ViVE. Thank you all so much. Enjoy your lunch. And these folks, I'm sure, will be available for celebrity photographer signings shortly.